Welcome to the deep dive. We're tackling a really critical medical issue today. Acute mesenteric ischemia, or AMI.
Mhm.
Think of it as a sudden blockage of blood flow to the intestines. It's a tough condition to spot and unfortunately has a very high mortality rate,
Hmm.
which makes understanding it all the more important.
Exactly. Time is absolutely the essence with AMI. It's like a race against the clock, really, to restore blood flow to the gut.
Right. And to really sort of get under the skin of how we've approached this, we're focusing on a significant study from 2002. It's in the Journal of Vascular Surgery by Park and colleagues.
Ah, yes, I know of one.
Contemporary Management of Acute Mesenteric Ischemia, Factors Associated with Survival. This paper looked back at a whole decade of cases, 1990 to 1999.
A crucial period.
So our goal in this deep dive is to pull out the key insights from this research, what it tells us about how AMI was handled then, and also to touch on how our knowledge has progressed since, thanks to other important studies.
Makes sense.
So to start us off, what did this study reveal about, well, how common AMI was and who was affected back in the 90s?
Okay, so this particular study looked at 58 patients. They all had surgery for AMI at their institution over that 10-year span. And a few things jump out. First, the demographics. Let's see, 22 men, 36 women. And the age range was really wide, 35 all the way up to 96 years. The average was around 67.
Hmm.
So it immediately tells you AMI isn't just, an older person's problem. It can hit a pretty diverse group.
And the telltale signs. I'd imagine severe abdominal pain is right up there.
Absolutely. Yeah, the study found a striking 95% of patients reported abdominal pain.
95%. Wow.
Now, of course, stomach pain can mean a lot of things, but its intensity, the sudden onset,
Wow.
that's definitely a major clue when you're thinking AMI. What's also interesting is that nearly half, 33% of these patients actually had a history of symptoms suggesting chronic mesenteric ischemia.
Ah, okay. That's a really key point. So for quite a few, this wasn't completely out of the blue. There were potential warning signs earlier on. Does this suggest maybe that catching and dealing with those chronic issues could be critical?
Precisely. I mean, as you connect the dots, it highlights this potential window, doesn't it?
Hmm.
For earlier intervention in patients we know have iffy blood flow to their intestines, maybe you could prevent the full-blown acute crisis.
And what about the underlying cause? What was actually happening with their arteries in these cases?
Right, so the study broke it down into three main culprits. You had embolism, that's where a clot travels from somewhere else, like the heart, and gets stuck in a mesenteric artery. That was about 28% of cases.
Okay.
Then thrombosis, where a clot forms right there in the mesenteric artery, often on top of existing plaque. That was the most common here, 64%.
64%. So thrombosis was the big one in this group.
You guys in this study, yes.
Right.
And then you had non-occlusive mesenteric ischemia, NMI. That's reduced blood flow without a physical blockage, maybe low blood pressure, severe illness.
Right, like in really sick patients.
Exactly. That accounted for about 8.6% here.
Okay, so these patients get diagnosed. Sounds like they're in pretty bad shape. What were the typical treatment pathways back in the 1990s, according to this paper?
Well, the initial diagnostic approach relied heavily on arteriography.
The dye and X-ray method.
That's the one, where they inject contrast dye to see the arteries. The study says it was used in 81% of patients. And for treatment, well, open surgical exploration was basically the standard for everyone in the study who was considered fit for surgery.
So surgery was pretty much the default. And what kind of operations are we talking about?
For the ones who could get revascularization, restoring the blood flow, they used several open techniques. Bypass grafting was commonest, creating a detour around the blockage. That was 22 patients.
Okay.
And thromboemblectomy, actually removing the clot, that was 19 patients. They also did things like patch angioplasty, widening the artery with a patch, or endarterectomy, scraping out the plaque buildup, even reimplantation in a couple of cases.
So quite a toolbox of open surgical techniques.
Yeah, definitely.
And given how serious this is, I guess the state of the bowel itself was a huge concern during these operations.
Oh, absolutely. A really significant number, 53%, actually needed bowel resection during that first surgery.
Or half.
Yeah. Removing damage or dead intestine just highlights how far the ischemia could progress before they got to operate. And then there's the whole concept of second look procedures, which is quite interesting.
Second look. What does that mean exactly?
It means in 23 patients, the surgeons plan to go back in, usually within about 24 to 48 hours after the first operation. The main reason was to reassess the bowel they'd left behind, check its viability.
Ah, I see. To see if more had become compromised.
Exactly. And in 11 of those second look ops, they did need to do more bowel resection. 9 of those were repeat resections, meaning they'd already lost some bowel the first time.
Wow.
It really shows you it's a dynamic process managing AMI. The full extent of the damage isn't always clear right away.
It sounds like a very proactive, maybe aggressive surgical strategy for the time.
It was.
What about less invasive options? The study period goes into the late 90s. Were they starting to dabble in anything like that?
Yes, they do mention it. There was some early experience with endovascular treatment, things like angioplasty, maybe stenting in 8 patients. So you get a little glimpse of these less invasive techniques emerging.
Just a glimpse, though.
Right. But open surgery was still very much the main player at that point.
Okay, so we've got a clearer picture now of the patients, the causes, the treatments in the 90s. What about the outcomes? How do these patients actually do? This is the crucial part, isn't it?
It is. And unfortunately, the study showed a pretty high 30-day mortality rate. It was 32% overall.
Nearly a third.
Yeah. And if you break it down by cause,
Mm-hmm.
it was 31% for embolism, 32% for thrombosis. Pretty similar there. But for non-occlusive mesenteric ischemia, NMI, the mortality was alarmingly high, 80%.
80%. Wow, that is a stark difference. Why so high for NMI?
Well, NMI often occurs in patients who are already critically ill from other causes,
Hmm.
like severe sepsis or heart failure. So they're starting from a much tougher place. The lack of a specific blockage also makes it harder to treat directly sometimes.
That makes sense. And what were the main reasons for death overall in the study?
The most common cause, listed for 18 patients, was multi-organ failure,
Right.
which really underlines the systemic hit that AMI causes. When the gut barrier breaks down due to lack of blood, it can trigger this massive inflammatory response that affects everything.
So the problem spreads way beyond just the gut.
Absolutely.
And looking beyond that initial 30 days, what were the longer-term survival prospects?
Also quite concerning, unfortunately, the study reported cumulative survival rates, let's see, only 59% at 90 days, down to 43% at 1 year, and just 32% still alive at 3 years.
Goodness.
And they compared this to a control population, finding it was significantly lower. And sadly, many of the later deaths were still related to the initial mesenteric ischemia or its complications.
A really serious condition with grim consequences, both short and long-term. Did the study find any factors linked to better survival? Any glimmers of hope?
Yes, there were a couple of things associated with better outcomes. Interestingly, patients younger than 60 years old tended to do better.
Okay, that's maybe not too surprising.
Right. But perhaps more counterintuitively, needing a bowel resection was also linked to improved survival.
Wait, needing bowel resection predicted better survival? That seems backwards. How could that be?
Yeah, it does sound odd at first, doesn't it? The authors suggested a possible reason. They proposed that patients who needed bowel resection might have had more severe, yes, but perhaps more localized disease. Disease that could be decisively treated by cutting out the dead section.
Ah, so removing the problem area definitively.
Possibly. Whereas those who didn't need resection might have had, say, more widespread ischemia, or maybe the damage was just too far gone systemically, even if the bowel looked okay initially. It could also reflect the surgeon seeing healthier tissue margins in those who got resected, allowing for a successful anastomosis. It suggests the pattern and timing of the disease might be key.
That explanation actually makes a lot of sense when you think about it that way. So, summing up this specific paper, what were the main conclusions the authors drew? What were their big takeaways?
Well, their findings generally supported the aggressive surgical approach of that era. Open revascularization, cutting out any non-viable bowel, and using those second-look operations. That seemed to help early survival, especially for embolism and thrombosis cases.
Right.
But they really highlighted the poor outcomes for older patients, those who didn't need bowel resection, perhaps indicating that more diffuse or untreatable disease, and especially those with NMI. And importantly, they strongly advocated for considering timely revascularization for patients who already had symptoms of chronic mesenteric ischemia, sort of a preventative measure.
Trying to head off the acute crisis before it happens.
Exactly.
Okay, it sounds like a really foundational study, painting a clear picture of the challenges back then. But, as we said earlier, things evolve. What has research shown since 2002?
That's right. Park et al. Was valuable, but it was a single center look back, focused mainly on open surgery. Subsequent work is built on it. For instance, there was a study by Ryer and colleagues in 2012. They look at the next decade, the 2000s. And interestingly, even with more use of endovascular therapies, the overall mortality rates were pretty similar.
Really? So even with less invasive techniques coming in, the death rates didn't drop dramatically?
Not across the board. According to that study, it suggests that maybe the timing of intervention is the bigger sticking point than just the technique itself. Are we still getting there too late?
That seems to be a recurring theme.
It does. Now, other studies, people like Kugias, Scali, Arthurs, Bewley, they've also looked into this, comparing open versus endovascular more directly. Some of that later research, particularly Arthurs and Bewley, did suggest a potential edge for endovascular therapy in certain ways. Maybe fewer complications like kidney injury or respiratory failure.
Okay, so maybe some benefits depending on the situation or the patient.
Potentially, yes. It's complex.
And what about newer techniques? We sometimes hear about things like ROMS, retrograde open mesenteric stenting.
ROMS, yes. That's a kind of hybrid approach. It combines an open surgical exposure, usually of the SMA downstream, with putting in a stent endovascularly, but often guided retrogradely, back towards the aorta.
So sort of the best of both worlds.
That's the idea. It can be useful for really tricky blockages right at the origin of the artery, where a purely catheter-based approach from the groin might be tough. Studies by Odrich and Roussel have shown pretty good results with ROMS in terms of keeping the artery open, what we call patency rates. But the mortality, especially in acute emergency settings, is still significant, although maybe lower in some reports than historical open surgery figures.
It just keeps coming back to how critical time is, doesn't it? You called it a stroke of the gut earlier.
Exactly. And just like with brain stroke or heart attack, how well patients do with AMI is hugely dependent on speed. Diagnosis, then intervention. Fast. Pretty much all the research since Park et al. Hammers this home. High mortality rates, the frequent need for bowel resection, it all points to diagnosis and treatment, often happening too late in the process for many patients.
But there has been some movement on trying to speed things up, right? Like specialized centers.
Yes, and this is a really promising direction, I think. Roussel and colleagues published on their experience setting up a dedicated intestinal stroke center.
An intestinal stroke center. I like that framing.
Me too. It emphasizes the urgency. They had protocols, a multidisciplinary team, all focused on rapid diagnosis, quick revascularization, whether endo or open, and surgery when needed. And their initial results were quite striking. Significantly lower 30-day mortality compared to previous benchmarks. Much better 2-year survival, too.
That sounds like real progress.
It does. Now, you could argue it might be a select group of patients, but it strongly suggests that reorganizing care, creating these specialized pathways to cut down delays, that's likely crucial for improving AMI outcomes.
So wrapping this up then, our deep dive into the Park study really drove home just how serious AMI is, the kinds of surgical strategies used back in the 90s, those really sobering mortality figures, and some factors that seem to matter for survival then.
Absolutely. And we've also traced how things have developed the rise of endovascular options, hybrid techniques like ROMS, but crucially, this growing realization that time is perhaps the biggest factor we need to conquer.
The intestinal stroke center idea really highlights that.
It does. It shows a potential path forward.
Which leads us to a final thought for you listening. We've seen that despite impressive advances in how we can physically restore blood flow, the surgical and endovascular techniques, the overall death rate from acute mesenteric ischemia remains stubbornly high. So, thinking about the future, where should the focus be? What are the most critical areas for research and for clinical practice? Is it about finding even earlier diagnostic markers, maybe?
Or perhaps better ways to identify and protect those at high risk before an acute event happens? Prophylactic strategies.
Or maybe it's about optimizing care after the initial intervention. That postoperative period seems critical, especially with things like multi-organ failure being common.
It's a tough, multifaceted problem, isn't it?
It really is. There's clearly still a long way to go, but hopefully continued focus and research will get us closer to better outcomes for patients facing this devastating condition. Thanks for taking this deep dive with us today.